So I think, so it's kind of a three-way talk, only probably I'm going to do most of the talking. If Leslie Cottrell can always add things. And I think Dr. Gupta has gotten tied up on a phone call, a clinical phone call. So I probably am going to give her vaccine update, which is challenging because you'll see why. So next slide. You already know why. So here is the most recent COVID data in kids. And I think we're all aware that Omicron has resulted in many more kids being admitted with COVID than we had seen previously. And I think there's a whole lot of reasons probably why that is. Some of it may be that kids were in the first year in 2020, they were sequestered and, you know, everybody was quarantining and schools weren't open. But then we know that Omicron is more contagious. But the good news is that there were, I had at the top there, more admissions, less severe. So markedly less kids in the ICU nationally than we have seen before, especially proportionally. We still had some kids in the ICU, but for this magnitude of jump of number of admissions, and especially in the 0 to 4 month olds, we really haven't had them in the ICU. Next slide. Now, you know, a little bit, and I'm no expert, but I did give you the article. You know, the Omicron variant is actually called BA.1, and there's actually the Omicron lineage that there's a .2, .3, and then there's a sublineage of BA1.1. And it's beyond really my simple mind, but I think these are related enough that they don't get their own name, like they're not renamed the next letter or so in the Greek alphabet. So BA.2 is circulating, and it is shown that it has an R naught number, or reproduction number that's 1.5 times that of the current Omicron. And that's worrisome because there's the appearance that this new one will be resistant, or is resistant, not will be, but is resistant to the new monoclonals, which, you know, the Delta variant monoclonals haven't really worked with Omicron. Now there's worry that the newer version isn't going to work with Omicron and not with the antivirals. And we really are worried about what protection we have from vaccination. So this is all very early, very new, and I do not know really any more than this, but I think this was an article just published last week from Japan, and has some a lot of very basic science data. So I think that the clinical stuff still is too soon to say. Next slide. So Shipper was going to talk about the vaccines, and we're all very disappointed. I'm sure you are. We were all waiting last week that we thought that you know, Pfizer had applied, that we thought there'd be a meeting at ACIP, and they withdrew the EUA on the 6 month to 4-year-olds. So just hit one more. Yeah, and this is how we all feel. So it's, you know, from what I can understand, and I think what we understand is that, so the vaccine, the Pfizer mRNA vaccine for adults and anyone 12 and up is 30 micrograms. The vaccine for 6 to 11-year-olds is a third of that, or 10 micrograms. And then the vaccine in the clinical trials for these kiddos who have gone through all this was 10% of the adult. So the adult was 30, is 3 micrograms. And I think now it's evident that 3 micrograms isn't enough. So that's why it wasn't approved in the fall. And then I think they were looking at doing a booster dose. And then now there are new trials in this age group of 10 micrograms. So it means that it's going to be probably months until we have any data and we have any vaccine. And you know, we're all very frustrated, and I don't have young kids, but there's a lot of people I work around, a lot of kids I take care of who are in this age group, and they're very frustrated parents. And you say, well, why not just go ahead and vaccinate a 4-year-old or a 3-year-old? They're basically the size, some of them, of 5-year-olds. And we do a lot of things that are not in the label, and that you know, we as physicians, as caretakers, take responsibility of. But I do understand that in the agreement for offices and places to get the vaccine, there is a clause that if you give the vaccine out of the age range, you will lose the privilege to have the vaccine and vaccinate. So basically, the CDC has said no. And so I think, as you know, my sentiment is that we're just like, we're very, very frustrated. So I guess we can talk a little more. I'm not sure there's more to talk about. So let's go to the next slide. So we've heard about long haul, long COVID. The NIH has given this name now, post-acute sequelae of COVID, or PACS. And you may say, well, what is long COVID? What is PACS? Well, there actually is no case definition or predetermined symptoms that have been published or that have been accepted in a consensus that this is what PACS or long COVID is. Next slide. So Dr. Cottrell and I have had, Leslie Cottrell and I have had the opportunity to be, she is PI, I'll be the clinical co-PI in this RECOVER clinical study. And actually Sally Hodder and the CTSI has been involved in the development of this, especially from the adult side. But we're the PI and co-PIs for the pediatric part. So this RECOVER is researching COVID to enhance recovery. And it is NIH funded, and it's an 11-state consortium. And it's tiered with the idea to enroll 80,000 adults, 20,000 kids. There is a group, not us, but a group who's going to look at electronic health records, millions of them, and then autopsy studies on patients who died of COVID or who had COVID. And I'm not sure if it's dying of COVID or die of something else after they had COVID. There could be iterations on that. So the idea is first to find out, there's a survey on REDCap, a fairly long survey, asking patient symptoms. And then the idea is to understand the pathobiology, as it's being called. And then the ultimate goal will be to figure out how to treat PASC or long COVID. Next slide. So there is an agreement, or there is the observation, I would say, that probably the three main symptoms of this PASC or long COVID is brain fog, anxiety, and fatigue. However, there's many more symptoms. So please don't think that I'm glossing over, but I think these are recognized. However, it's also recognized that if you were hospitalized with another illness, especially in the ICU or in the hospital, you needed rehab, you had a pneumonia that was not COVID, you might have some of these symptoms. So it's the recognition that not only do we need to enroll people who have symptoms, but we need a control group. So next slide. So if you go to the website, which is recovercovidstudies.org, you'll see similar pages like this. There is not the map of showing the centers that are enrolling is still in a work in progress. We're not ready. We're not accepting phone calls. We're not accepting patients yet. Stay tuned on that. I think there's been some press on NPR about this. So there are many adult patients who have heard about this Recover study and have been calling around and wanting to know more about it. And I'm not exactly sure when we're going to start, but we're sometime this year. I mean, we're in the process, but we will be enrolling both adults and kids. And this is separate from a long COVID ID clinic. So our ID folks have a separate clinic. You can call and say, I want to send an adult to long COVID clinic. They go, okay, they pull it up and they put them in. We've been getting questions on pediatrics, and basically those kids come to Peds ID. So there's 3 of us, and we have openings pretty much every week. And we, we will see them now. But I think that for people who are looking for a clinical answer and treatment, and help and treatment now, this is not the place for them, but hopefully they will come here to help us to gather data in a research forum to answer a whole lot of questions. Next slide. So how's it going to work? Well, we're going to follow people for 4 years, and we're going to kind of have these different cohorts. We're going to have newly diagnosed, had COVID within the last 30 days, now have symptoms of fatigue or brain fog or whatever. People who had previous COVID, so anybody after March 20th, 2020, who's had COVID, who thinks they have long COVID, potentially, is eligible. And then there will be a COVID negative group who will be a control group. We do know, so over on the left, the little thing, the associations of people who develop PASC or long COVID are obesity, diabetes, and if you have pulmonary symptoms of COVID. But actually what we also know is that people who had relatively mild symptoms, never needed to be in the ER or hospitalized or anything, can have symptoms as well. So someone shouldn't think, well, I didn't have that, I'm not in that group, so I don't count. I think we are trying to understand, why is someone at risk? Why does it occur? What can we do to help? All those questions. Next slide. So as I said, if it's recent COVID, 4 weeks after COVID, there's always the question, is this a new illness or is this another illness on top of an initial illness? Those are a lot of things that are going to be dealt with in this study. And it is a moving target because it's not like we're in a bubble and no one else is going to get COVID again. You could be reinfected. The control group could be infected. And also it is not, your vaccine status is not playing a role here. Now, it may be that when we start to enroll, especially adults, there may be, these are only adults who've been vaccinated. We need to have people who haven't been vaccinated. I don't know. That might be a confounder, but we definitely know that there are people in both groups who have symptoms of long COVID or PASC. So, so that is not an inclusion or an exclusion. So the goals are really to define the illness and then nail down the prevalence, because we've seen anything from, I've seen as high as 50%. I think some people think realistically, maybe it's 25 to 30% of people who have recovered from COVID. That's a lot of people, a lot of people. Next slide. So how is the study going to work? Well, there's 3 tiers. So the first tier will be that someone is eligible and they get blood work done, and it's about a 15-page survey on REDCap. And I'm told that it takes somewhere between 25 to 45 minutes, so people shouldn't be intimidated by the length of the survey. And then the answers to the questions will trigger whether a patient moves into what we call tier 2 or tier 3. Now, tier 2 is getting an echo, maybe getting an MRI, A tier 3 is maybe getting an endoscopy or upper scope or more invasive. And that will be determined by first, the tier 1. So we really don't know at this point. I don't know how many kids we're going to have in tier 2 or tier 3. I imagine there's going to be more adults who will be in those. Now, there is a real concern and an effort to be aware that we include underrepresented populations. So those people who've already heard the NPR story are perhaps a different demographic than many of our patients in rural West Virginia or in any inner city minority populations or Native American populations. So, and do you have internet access? Do you have, what? So there's a real effort with this, and the NIH is determined that that we include underrepresented populations. And kudos to Sally Hodder, because she's really been on the forefront with this study and with putting West Virginia right out there to include our patients and people of West Virginia. So I said maybe 50%, we think maybe, but it's estimated that perhaps we're going to find 25 to 30% of patients who've had COVID infection may have PACS. And then there also is going to be a limit to the number of people who are post-ICU. Because if you enroll half of the patients who enroll are adults, because we don't have that many kids, but who have been in the ICU on a ventilator, you're maybe going to skew the data a little bit compared to all the rest of the other adults who maybe were hospitalized or maybe not hospitalized. So I think that there's going to be a look at who gets enrolled, and these post-ICU patients really have to be compared to other non-COVID post-ICU patients in terms of some of those symptoms. Next slide. So that's actually all the slides I have about this. If you want to hear a really interesting talk about this study, it's a 22-minute, I think, or something, 16-minute maybe, I don't know, not very long, podcast called Studying Long COVID. And it's a New England Journal website. You can find it, and it's an interview from February 2nd and talks about the study. So I will open it up to the chat and see what people have to say.
Great, thank you so much, Dr. Moffat. Really appreciate your time. I have one question that was sent in from a spoke. It's sort of like a 3-part question, and part of it was answered, but we just want to make sure everything was covered and it pertains to long COVID. Is there anywhere, obviously we're starting to study it, but in WU studying it, is it real? And what should primary care physicians be looking for that guidance of the definition?
So it's very real. I think that we don't know the exact number of symptoms that a patient needs to have, but it's recognized that after 30 days, from the date the person gets COVID, if they still have symptoms 30 days later, and it can be shortness of breath, it can be fatigue, it can be brain fog, anxiety. There's some evidence that exercise doesn't help. Or it's complex how exercise helps, because you usually think when someone, say, has a chronic fatigue from another illness, you get them, they're deconditioned, and you get them moving and you get them working, and yet rather interesting. So I think if there's symptoms that are not explained by another reason and the person has recently or in the past had COVID, I think that's a reason. And usually all the tests are negative. So CBC is negative, any other BMP, other blood work's negative. They don't have residual pneumonia. I mean, an X-ray may be, recovering from whatever they had or be normal. So it's the puzzle that we do testing and we find things to be normal, and yet the person is not crazy. I think we know that we have done that in medicine before, where we say, oh yeah, well, they're just crazy. No, they're not crazy, because there's enough people who are repeating that have these different, and you don't have to have all of them, but the different constellation of symptoms, and trying to figure out how to help them.
Absolutely. Thank you so much for providing that. A spoke said they had long COVID in 2020 and are a patient, but the closest clinic they could find was in Ohio. They're being treated in their clinics through Cincinnati University. Excited they were moving this direction, wondering when appropriate could I get referred to participate in this study.
Yeah, so that's, I'm glad you're getting treatment, and if it's working there, go there instead of coming here. I mean, I know that our adult ID now has a long COVID clinic, but in terms of you getting in the study, hopefully the folks in, Cincinnati should be aware of this, but get that, look at the website and stay tuned on that website. The Recover, here, I'll tell you what it is. It's recovercovidstudies.org. It's all one word. And I think if you put in Recover COVID, it probably would come up. But they have a website, but we've not yet opened. And there is a map on there of the United States, but then it says, not ready for prime time or whatever it says on there. But when they are ready to enroll, I think then you'll be able to click on West Virginia and click on Morgantown or Cincinnati. I don't know if Cincinnati is participating. I would assume, it's a huge, big study. So.
Excellent. Thank you. Mitra put that into the chat.
Good.
So if you click that link, you can follow it. Also include that into our recap. And, so would that be finding a long COVID clinic? Is that the resource you would find? Is there one in Morgantown as of yet?
I believe there is. Yeah. For adults. Perfect. I mean, that's called that. We will see any kid in our infectious disease clinic. We're just not calling it a long COVID clinic, but it's coming to see Peds ID, and then we will help to figure out what's needed. We don't have enough yet to actually have a separate day and time, but there's 3 of us and we're available. Usually there's spots any day of the week almost that you could see one of us.
Great, thank you so much. Let's see. Early, there were reports of POTS being a feature of long COVID. Is that still being reported?
I'm not sure. John or Marty, anybody want to chime in? What they know? What happened to Marty? His name was on here. Did he leave?
Yeah, he's still here. Dr. Gilfus, I saw that you
I don't have any knowledge on it at all. Other than, by the way, the Recover trial, I know there's somebody who's actually seen here today for it. Like one of our providers saw someone already for the Recover trial this morning at 8 o'clock. So I guess they're seeing people already from that perspective.
Okay, well, adult-wise, peds were not yet, but I guess adult-wise they are.
Yeah, and then Soari and Reese are running the long COVID clinic here. So I'm probably the worst one I kind of logged on to learn about it. Less expertise than more wanting to learn about it. But yeah, I agree with Dr. Moffitt so much about this concept of patients are not crazy just because the lab test is not abnormal. The hepatitis C taught us that. Lyme disease taught us that. There's a whole bunch of diseases that have this post-infectious inflammatory milieu that may not give you a high SED rate, but you feel awful for a long time. I'm a bona fide believer, and can't wait till we can help people.
Thank you so much for that, Dr. Gilfus. Completely agreed. Does anybody else have any questions or comments they would like to make? They can unmute, raise their hand, or chat that in for us, please.
There's the question in the chat about postural orthostatic changes. I saw a kid the other day who was a teenager who had COVID, and whether you call it POTS or you just call it part of the post-COVID syndrome, I don't know. But still, some of the same principles seem to, plenty of fluids, increased salt intake, and what have you. But the thing is that what's going to be interesting about this, I suppose, is just like saying the heterogeneity of the different people who come in with various complaints, and all of them are going to be after COVID, and sorting out, what are all of these different syndromes, and are they the same syndrome just with different manifestations?
And Dr. Moffat, I'm sorry if I missed, I just logged on. I liked the part you said about an exclusionary diagnosis. The real challenge in these COVID patients, we see so many weird things, genuine opportunistic infections after COVID, especially if they've gotten dexamethasone or toci or baricitinib. We've seen basically all the pathogens of the mid-'80s HIV outbreak. A PCP, Cryptococcus, PCP, you name it, it's on the list. CMV. So it's a challenge when these patients come in with complaints post-COVID. To label someone COVID is extremely exclusionary diagnosis. You got to rule out a lot of that stuff too.
Yeah, we've been lucky in many areas. I mean, COVID has turned all our lives upside down, and PEDS ID, our lives are upside down. And yet the burden of that kind of disease, we don't have in pediatrics.
That's awesome.
And hopefully we never will. I mean, we've had some really, really sick kids and in the ICU, and we've only had one death, and it was last summer, and it was a girl with myocarditis from MISC, and she was down in the field, literally in a field in a tent, and found by her friends, and so had really suffered brain damage and further probably heart damage. And so she died several days later. The family withdrew care because that's the only death we've had. So yeah, I'm grateful that we're not seeing the PCPs and the Mucor and the Cryptococcus and all of that in peds. And maybe just because we don't have a big enough numbers here, but I think overall in pediatrics, we're really not seeing that to the extent that you guys are. So.
Thank you so much for those comments. We saw another thing in the chat, arriving soon, code U09.9, post-COVID-19 condition. Dr. Pollywall, did you want to expand, or anybody else want to expand about that?
I mean, it's just the ICD-10 code that we can use in our diagnosis. I'm sure if we use this ICD-10 code, it will help generate necessary statistics when we are doing any kind of study or research in future.
Right. Because otherwise you search for things to put in. Fatigue, that's really, and brain fog, I don't think exists as a diagnosis. So that's actually, thank you for putting that in. That's really helpful, because I think that's a way that, the medical records can be searched, and we can learn more and more about this.
Great, thank you so much. Thank you, Dr. Pollywall. Does anybody else have any comments or remarks or questions before we end our session today? I know feels like COVID's never leaving, but I'm feeling a little more positive about it than I have in the past. So that's nice.
All right. Well, it was a short one, but short but sweet. Everybody gets 15 more minutes of their lunch break before you have to go back to do things at 1. So thank you. Thanks for inviting me again. I hope I found this.
Dr. Moffat, Jennifer, did you have a question?
No, I just wanted to say thank you. It was just great. Thanks to everybody who's on the call, but thanks to everyone.
Yeah.
And then one more question, I'm sorry, who does someone contact to get an appointment at WU's long COVID clinic?
Oh, it would be scheduling. Here, let me look and see if I have a number for the, I don't know if I do. I mean, I have the number for peds appointments. I don't have the number on my phone. For peds appointments, it's 304-598-4835. I don't know what the adult, they may have a tree there and can direct you to adult to
Perfect.
get a, probably is it the same? I don't know.
Thank you so much. Great talk. I agree. And then our next one will be March 17th. So we'll see you in a month and more to come about that next session. Thank you for your time and have a great rest of your week.
Thanks.
Bye.
Bye.